Okay, now let's continue with cardiovascular pathology. In this video, we're going to look at left-sided heart failure. In my previous video, we looked at heart failure, an introduction to heart failure, where we looked at some of the causes of heart failure. And some of the causes were ischemic heart disease, hypertension, and primary heart diseases such as amyloidosis, which is deposition of misfolded proteins in the myocardium. So now, we're going to look at left-sided heart failure. Now, in left-sided heart failure, we're talking about the left heart, where we're talking about the left ventricle and the left atria. Okay, so heart failure, we said it is the failure of the heart to pump adequate blood to the tissues. Okay, so if it is right-sided heart failure, meaning we're talking about the right heart failing to pump blood to the pulmonary circulation. And if it is the left, meaning we're talking about the left ventricle failing to pump blood to the tissues. Okay, so left-sided heart failure may be caused by a number of things, but some of them are ischemic heart disease, where we have the myocardium becoming ischemic. We have low oxygen supply to the myocardium, and that may lead to necrosis. Some cells will start dying, and the heart will fail to contract properly to pump blood to the tissues. And apart from that, we have systemic hypertension. We know that in hypertension, we have increased pressure. So systemic pressures are increased, meaning the heart has to pump blood with more force. Okay, so it has to pump blood more than normal, and that after some time it can lead to heart failure, that is hypertension. And then mitral or aortic valve disease, such as stenosis or calcification of the valves, can also lead to left-sided heart failure. So here we're talking about these valves, the valves between the left ventricle and the right and the left atrium. So if this mitral valve fails, if there is any inflammation or disease in those valves, meaning blood won't be pumped properly into the left ventricle, and the blood which will be pumped into the aorta, into the systemic circulation, will be less, and that will result into that will lead to left heart failure or the left-sided heart failure. Okay, and apart from the mitral valve or even the aortic valve, if we have any problem, any disorder in the aortic valve as well, we are going to have accumulation of blood in the left ventricle. Blood won't be pumped properly into the aorta, and that will lead to left-sided heart failure. So apart from these three, we also have primary diseases of the myocardium, such as amyloidosis. So this is simply accumulation of misfolded proteins in the myocardium. So if this accumulation of misfolded proteins is excessive, it will alter the contraction of the heart. Okay, it will disturb the myocardium to stretch properly, and that can lead to left-sided heart failure. Okay, so the morphological and clinical effects of left-sided heart failure, mostly it is to do with systemic perfusion. You know, we are going to have less blood which is going to be pumped into the systemic circulation, and that will bring systemic perfusion problems. And apart from that, we also have elevated back pressure within the pulmonary circulation. We know that the blood which is received by the left atria comes from the pulmonary circulation. So if we have any problems here which leads to left heart failure, we are going to have the pressure is going to backflow. So meaning we are going to congest the pulmonary circulation, since this blood is coming from the lungs. Okay, so those are some of the complications or the effects of left-sided congestive heart failure. Okay, so we are done with the etiology of left-sided heart failure. Now let's move on to the morphologic features. So the morphologic features depends on the underlying cause. So the features that are going to be observed will depend on the cause of the heart failure. So if the heart failure is caused by a high hypertension, meaning the left ventricle will be hypertrophied. Okay, we are going to observe hypertrophy in the left ventricle. Okay, so this hypertrophy can be as a result of volume overload or pressure overload, as we discussed in my first video. So if it is volume overload, meaning the left ventricle is going to be dilated, so we are going to have our left ventricle, this ventricle here is going to be dilated if it is in volume overload. But in pressure overload, we are going to have thickening of the thickness of the left ventricle is going to increase. Okay, so it is going to become thickened. Why? Because the sarcomeres will be added in parallel. So if you have, this is the sarcomere, another one will be added in parallel to the first one, and this will increase the thickness of the myocardium. That is in pressure overload. But in volume overload, what will be observed is that the sarcomeres will be added in series. So what will increase is just the length, meaning in volume overload, we are going to have dilation of the left ventricle. Okay, so apart from hypertrophy, we also have other morphologic features such as mitral insufficiency. Okay, so if we have the left ventricle being dilated, that can result in mitral insufficient. So the mitral valve is going to be insufficient here. Why? Because this part here is dilated. So once it is dilated, it's going to affect the mitral valve. Okay, so it is going to affect the mitral valve, and also we are going to observe left atrial enlargement. Okay, so why enlargement? This is because when the mitral valve is failing, so blood will start accumulating in the left atria, and that will lead to volume overload, and volume overload also always result in enlargement. Okay, so if left atria is enlarged, that will cause atrial fibrillation. Okay, that will cause atrial fibrillation, and atrial fibrillation will result in irregular arrhythmias, and that will also affect the cardiac output in the run. Okay, so other microscopic changes. So microscopic changes which will be observed, will see the myocyte being hypertrophied. So myocyte hypertrophy with interstitial fibrosis will be there, more especially in ischemic heart disease. We are going to observe high fibrosis there. Okay, so due to compensation, we are going to observe hypertrophy of the myocyte. Okay, and then apart from that, in the background, okay, so we are going to have lesions in the background. Okay, and this is mostly due to recent or old myocardial infarction. Okay, so due to old or recent myocardial infarction, we are going to see lesions in the background. So we also have morphologic features which are seen in the lungs as a result of left-sided heart failure. So in the lungs, we are going to have congestion. Okay, congestion, edema, and pleural effusion. Why? Because of increased hydrostatic pressure. Increased hydrostatic pressure. So due to increased hydrostatic pressure, we are going to have congestion there. So we know that the heart receives blood from the lungs. Okay, from the lungs. So if we have heart failure, left-sided heart failure, that blood will start flowing back into the lungs. So that will cause increase in the hydrostatic pressure, and that increase in the hydrostatic pressure will lead to congestion. And then congestion in most cases will cause edema. Why? Because we have accumulation of blood there, and if blood starts to accumulate, hydrostatic pressure as well also increase, and fluids will start leaking out of the blood vessels into the interstitium, and that will be edema. And pleural effusion as well, the same mechanism. Okay, then apart from that, we are going to due to edema and congestion, pleural effusion, the lungs will be heavy and boggy. Okay, so boggy here means it will be wet. So due to accumulation of fluids, that is edema. So it will be heavy and boggy. Okay, it will be wet. Okay, so microscopically, we'll show perivascular and interstitial transudates. So transudate is simply a fluid with little or no proteins in it. Okay, so we are going to have accumulation of this transudate in the interstitium or in the perivascular. In the perivasculature, we are going to have a transudate, and then in the septal of the alveolar, we are going to have edema. So alveolar septal edema is also going to be observed, and accumulation of edema fluid in the alveolar spaces, and this will lead to cough reflexes. Why? Because if you have excess fluid accumulating in the alveolar spaces, that will cause edema. Okay, that will lead to edema. If you have fluid accumulating in the alveolar spaces, then a cough reflex will be initiated. So in clinical features, we are going to have cough. So in chronic heart failure, we are going to have variable numbers of cells extravasate from the leaky capillaries into the alveolar spaces. So in the alveolar spaces, we are going to have accumulation of red blood cells, and these red blood cells will be engulfed or will be phagocytosed by the macrophages. Okay, and then the red blood cells, we know that there is iron, and we also have in the hemoglobin. So breaking down of those red blood cells and the hemoglobin will cause what we call will lead to macrophages being laden with the hemostatin. Okay, hemostatin will be accumulated in the macrophages, and these macrophages are what we call heart failure cells. Okay, heart failure cells. So these cells, when they are observed in the lungs, meaning we suspect heart failure, either chronic or acute. So these cells which are observed here. So these are the alveolar spaces, but we have accumulation of macrophages which are laden with the hemostatin. Okay, hemostatin. Okay, so those macrophages, once observed, they are called heart failure cells. So moving on now to the clinical features. So under clinical features, we're going to have dyspnea, which is shortness of breath. Okay, so this is the earliest and most significant symptom of left-sided heart failure. And then apart from dyspnea, we're going to have cough. Due to accumulation of fluid in the alveolar spaces, a cough reflex will be initiated. Then if the patient lies flat down on the ground, we are going to have orthonia. Okay, orthonia is going to be observed. Now this is when the patient lies down on the ground, and when he lies down on the ground, he fails to breathe. He's is going to have shortness of breath, and that is corrected when the patient sleeps in a semi-seated position. Okay, so if the patient lies down on the ground like that, it's going to have trouble in breathing while lying down. But in this position, and that is corrected by sleeping in this position where you are just sleeping in a semi-seated position. Okay, that is what we call orthonia. And then apart from that, we also have paroxysmal nocturnal dyspnea. So this is when that patient sleeps after an hour or 2 hours, he feels shortness of breath and wakes up. So that is what we call paroxysmal nocturnal dyspnea. Okay, so apart from these four clinical features, we also have other manifestations. Okay, manifestations such as cardiomegaly, that is enlargement of the heart, and then we also have tachycardia, and we may also hear a third heart sound. This is due to mitral or aortic valve problems. And we also have other sounds which are called rails at the at the lung bases. So at the base of the lung, you are going to have a creaking sound which is called rails. Okay, and that is caused by opening of the edematous pulmonary alveolar. So those alveolar which have edema, when they open, okay, when they open during ventilation, we are going to have clicking sounds which are called rails at the base, at the lung bases. Okay, then apart from that, we also have ventricular dilation. We have already talked about that. Okay, we have ventricular dilation, and also we have the papillary muscles. Those muscles which holds the valves will be displaced outward, and that will cause mitral regurgitation. The mitral won't be function properly, and we are going to have systolic murmur, systolic sounds. Okay, now if in chronic dilations of the left atria, that can cause atrial fibrillation, and we know that atrial fibrillation is associated with left dilation of the left atria, and that will lead to irregular heartbeats. Irregular heartbeats. Okay, so if you have a problem in the left atria, we know that even the stroke volume is going to be affected. The stroke volume will be affected, and apart from that, if the left atria is dilated, we are going to have we are going to cause stasis of blood. So blood will become stagnant, and once blood becomes stagnant, we know that a thrombi can be formed there, and once a thrombi is formed, that will lead to the thrombi can shed an emboli. Okay, so in the wall there of the blood vessel, a thrombi due to in the atria. So in the atria there, if we have stasis, blood is just is not moving properly there, we can have formation of a thrombi on the wall of the left atria. And if this thrombi is shed out in the blood, it is now going to be called an emboli, and that emboli can break into small pieces of emboli which can block blood vessels in different organs. If it is in the brain, then that can lead to stroke. Okay, and if it is in other organs, then that can lead to infarction. Okay, so some tissues will be dying in those other solid organs, such as the kidneys and even in the lungs and the other parts of the body. Okay, so apart from that, we also have diminished cardiac output. So if we have heart failure, the cardiac output will be less, and that will will decrease renal perfusion. So if the renal perfusion is decreased, we know that the RAS system will be activated. The renin-angiotensin-aldosterone system will be activated, and renin, in this system we have renin being released by the juxtaglomerular cells, and once renin is released, it is going to convert angiotensin into angiotensin 1, and angiotensin converting enzyme is going to convert angiotensin 1 into angiotensin 2, and that angiotensin 2 is going to cause release of aldosterone by the adrenal gland. And the aldosterone, we know that it is going to increase the intravascular volume by retaining salt in the blood. So once salt is retained, even water is going to follow. So that will increase intravascular volume, and the pressure is going to increase. And once this happens, pulmonary edema will be exacerbated. The pulmonary edema is going to be increased, and that will also lead to other problems that we have already discussed. So with further progression of congestive heart failure, we are going to have azotemia, which is simply increase in creatinine in the blood, and also we will have excretion of impaired excretion of nitrogenous wastes. Okay, so in the kidney we have failure. The kidney will also start to have some problems that will lead to azotemia, and azotemia also we are going to have impaired excretion of nitrogenous wastes, and also increased metabolic derangement. Okay, so in severe cases we will have the blood which will be supplied to the brain will be diminished. Okay, and that will lead to hypoxic encephalopathy, and this condition is marked with diminished cognition, poor cognition, and we're also going to have restlessness. Okay, that can progress to stupor or coma. So in the cerebral perfusion is reduced, we are going to have hypoxic encephalopathy, which is marked by poor cognition, and also have restlessness, which can lead to stupor or coma. Okay, so thank you so much for watching. Don't forget to like, subscribe, and leave your comment concerning this video in the comment section.